One, welcome back to the Heart, Chapter 20, Part 2. Here we are. This chapter, as we said, focuses on the heart. First section really looked at the anatomy of the heart, and we looked at some of the essential physiology, like the blood flow through the heart, the actual conducting system, and the cardiac action potential. In this section, we're going to be focusing especially on cardiodynamics, this aspect of how do the pressures and the changes of the heart throughout the cycle of beats, how does this cause blood to move? And that's kind of what we're going to be looking at. So the big idea here is let's start everything off. And what we want to make sure we understand is one important key term that's going to set a lot of what we're talking about is the cardiac cycle. Now, the cardiac cycle, if I've got a heartbeat to another heartbeat, I'm getting ready. I have the start of one heartbeat and then the beginning of another heartbeat. There is the start of one all the way to you start to begin another one. So it is one, I would say one lub dub, one lub dub, a one pump pump of the heart. Okay. A full, so there are two major phases that we can break down the cardiac cycle in if we're going to have a lub dub. To have a lub dub, you're going to have both contractions and relaxations of the heart to move blood through the heart. If you remember from the last lecture, I related this to a chemistry professor who retired from our college, who had a reputation for being very much like, "Oh, I'm gonna fail half of you in by the first exam," and students would just drop out of the class sometimes after the first lecture, and they would go try to find another professor because he was just so much like that. But just like to he just that's the way he was. So students kind of went from an area of high pressure to area of lower pressure. Fluids move from high pressure to low pressure, higher pressures to lower pressures. So how do we get a pressure to go up? How do we get a pressure to go down in the heart? Well, to get a pressure to go up, we contract a chamber. To get the pressure to go down, we relax a chamber. So what is that? These are the two major phases called systole and diastole. Systole, a good way to remember that systole is the contraction of a chamber, is that it squeezes. Systole is when a chamber squeezes or contracts. And this heart chamber, like an atria, undergoes systole, or a ventricle undergoes systole, that contracts, and that increases pressure inside that chamber. Now, anytime that you squeeze a chamber, anytime it contracts, the blood in that chamber is going to be pushed out. Blood leaves it. Now, sometimes it's easier, sometimes it's harder, but blood will leave chambers when you squeeze it. Now, unless for some reason you can't squeeze it hard enough, and those things can happen. We'll talk about something that can affect the amount of blood that comes out later. Now, diastole is relaxation of a chamber. Chamber relaxes. Now, when a chamber like an atria undergoes diastole, a ventricle undergoes diastole, that chamber relaxes, and when it does, the pressure drops. The pressure decreases inside that chamber. And when you have lower pressures, blood likes to enter and fill and come into a chamber that is undergoing relaxation or diastole. I oftentimes like to say there's plenty of time to relax after you die, diastole. That is, people used to say, I can rest when I die. That was a phrase that was used sometimes. So we could say that systole squeezes, diastole is a relaxation. Okay. Now, in this, what we want to understand is that these pressures are going to be undergoing these forces, the contractions and relaxations of atria and ventricles. Both atria, both ventricles undergo systole and diastole. And when they do this, blood will move. And remember, blood's going to move through either the semilunar valves or an atrioventricular valve as it moves through the heart. If it wants to go from atria to ventricle, you have to go through the AV valve. If you want to go from a ventricle out to a vessel like a pulmonary artery or an aorta, you have to go through the semilunar valves. Now, also, remember, systole squeezes, diastole relaxation. Okay, with that, we have to understand that the atria will undergo systole and diastole. The ventricles will undergo systole and diastole. Now, why does that happen? It happened because of this system right here times it. Okay, this is what sets the timing. This is why I like to think of this as the timing system in your car of these series of spark plugs firing at the right time so that the car ignites and you can produce power from the engine. Now, what I normally do when I'm in class is I have a dance that I do. But I can't do that here. A couple things. Number one, I'm teaching at home, and etc. So, what I wanted to do is kind of describe this a little bit differently. And what I want to help you guys grasp is that with the atrial systole, okay, we have to begin somewhere. We're going to begin at atrial systole. And what we are going to begin with is a ventricle that is mostly full of blood. So the ventricle is mostly full of blood. The ventricles are mostly filled. You're like, but you're talking about atria. I know. Remember, the atria, when they contract, the AV valve, the AV node, has the job to delay the signal from going down to the ventricles to allow the ventricles to fill with blood. So that's what's kind of going on here. So first off, we have our ventricles are mostly full of blood. So what's going to happen is our atria will squeeze. And what are they squeezing? They're squeezing the remaining amount of blood that was in the atria. Atria has some blood still in it. The atria squeeze, and that will force open the AV valves, the left and the right atrioventricular valves, bicuspid, tricuspid valve, tricuspid, bicuspid valve. Okay, they will open. But that's because the atria. Now think about this. What's kind of going on here, guys, is the atria are sitting here producing pressures that open the AV valves, and the ventricles produce pressures that close AV valves. Ventricles also produce pressure that open semilunars. So with that knowledge in mind, if we understand blood flow as we did last lecture, you guys should see that during an atrial systole, where we take the remaining amount of atrial blood, squeeze it into the ventricles, that the AV valves surely would be open, but the semilunar valves could not be because there is no force exerting on them yet. So atrial systole ends, and then atria undergo diastole. When the atria undergo diastole, now the atria are no longer squeezing. They're no longer putting pressure onto the AV valves. The AV valves will close. So all valves will be closed during the end of atrial systole and the start of atrial diastole. And I kind of wish I put atrial diastole in bold because I kind of got 2 for 1 here on that. Now, what is going to happen is we have this 2-part subpart of ventricular systole. Okay, so we have to understand that the ventricles are now full as they are going to be. The heart has supplied as much blood at the ventricle now. After atrial systole ends, the ventricles are as full as they're going to be. Now, what starts to happen is that ventricular systole, remember, is squeezing. The heart starts to squeeze, the ventricle muscles squeeze, and that pushes the AV valves closed, but there is pressure trying to push against the semilunar valves. Now, what is happening is your semilunar valves here, guys, they have blood pushing down from the aorta and the pulmonary trunk, pushing down on them. And that force of blood pushing down on them creates a force that the ventricles have to overcome. Now, the ventricle is contracting, but it is not yet produced enough force to overcome the pressures in the pulmonary trunk and the aorta yet. So though the ventricle is contracting, there is no blood leaving the ventricles. So you still have semilunars are closed. What's happening is you're not producing enough to open them. This is referred to as an isovolumetric contraction. And under isovolumetric contraction, the heart is contracting, the ventricle walls are contracting, but they are not producing enough force yet to overcome the blood that is pushing down on the semilunar valves. So the AV valves are still closed. The heart is contracting and not ejecting blood yet. Then at the end of ventricular systole, it rises enough to exceed the pressure that is inside the aorta and inside the pulmonary trunk, and we have what is called a cardiac ejection, where blood shoots out of your semilunars. So the semilunar valves open, blood is ejected. It's either going out to the pulmonary trunk, pulmonary arteries, and lungs, or it's going to go out the aorta and then all the branches of aorta to the body systems. Now, the AV valves remain closed under normal functioning because you should know that the papillary muscles, the chordae tendineae, help prevent the semilunar valves from backflowing and allowing blood to backflow. Now, when this happens and the ventricles relax, the ventricular pressures drop and blood pushes down onto the semilunar valves, and that closes them. Now, what is happening here during ventricular diastole is a very interesting thing. The atria is relaxed and blood starts coming in. Okay, blood will start coming into the atria, and the atria are full, filling up anyway. Now, it is filling the atria because they are relaxed as venous return comes into the heart, but it is not producing, there's not enough blood in the heart yet, into the atria yet, to open the valves. Now, what will happen is, during ventricular diastole, late at ventricular diastole, though all the chambers are relaxed, the AV valves open because there is enough blood in the atria to push and open up the AV valves. So we call this passive filling. And it is passive filling that gets us to the mostly filled ventricle. That allows atrial systole to squeeze the remaining blood, opening the AV valves up, filling up the ventricles. Ventricles start to do an isovolumetric contraction that does not move blood until it produces enough pressure to do a cardiac ejection. Then everything relaxes, blood starts coming back to the atria, ventricular diastole happens. And you can actually begin to see that, okay, if we start here and we have a mostly filled ventricle with blood, the atria will squeeze and push the remaining amount of blood into the ventricle. Now, the atrial diastole, it relaxes, and then the ventricles start to contract as they push the AV valves close, but they are not producing enough pressures to open these semilunar valves. And that is called isovolumetric contraction. Then, once they overcome that, blood goes out the pulmonary trunk, pulmonary arteries and lungs, and the aorta. Then all of our valves will close as the atria begin to fill with blood, and then enough blood gets into the atria that it opens the AV valves and passively fills the ventricles so that we can begin the cardiac cycle with a mostly filled ventricle. It's kind of like you want to begin a road trip with a full gas tank. You want to begin the cardiac cycle with a filled ventricle or a mostly filled ventricle. And that's kind of the way sometimes I think about it. Now, the steps of that is something you will definitely need to break down. As I said, now it takes about 800 milliseconds. I do not worry about the timings as much as we understand the forces and how this makes blood move through in a normal cardiac cycle. And you will see questions that ask very specifically about events of cardiac cycle, when the valves may be open, when the valves may be closed, which valves are open, which valves are closed, where is blood moving, and how is this happening. The timing is all done with this. And this is what is happening. So this diagram right here, if you watch this animation, it kind of helps you understand a basic cardiac cycle. You can barely see the short isovolumetric contraction on that, but this diagram really does a great job of showing it. Now, what I want to do is these are the pressures. I'm going to look at the pressures. I'm going to look at the volume changes. This is a diagram oftentimes referred to as a Wiggers diagram. Dr. Wiggers is the person who graphed this out. And what we're going to look at, the pressures in the aorta, the pressures in the ventricles, the pressures in the atria. Okay, now we said we begin with a mostly filled ventricle. Right here, we are at a mostly filled ventricle. Now, we can go up as high as here, but we are most of the way there. So what you notice is right here, when the atria starts to fill with the last of its blood, you will notice that the atrial pressures go up. That is the squeezing of the atria here. Atrial pressure, left atrium squeezed the blood into the ventricle, okay? Then the ventricle starts to squeeze, creating pressures. Now notice right here, there is this, it's squeezing here. Notice that for this time, notice the volume of the left ventricle stays the same, though the pressures are going up. And right about here, right about 80 millimeters of mercury of pressure, the valve opens right around 80 millimeters of mercury. Right around that mark, about 80 millimeters of mercury of pressure. Then it opens up and the volume of blood goes out. That was our ventricular cardiac ejection. Then, as the atria start to refill, the passive filling of the heart, the active atrial systole filling up the heart the rest of the way, and us going through another cycle of that, okay? And that's what's happening. And I think this really helps you see a little bit of these forces and what's happening. I'm not going to go over every single force that's on here right now, but one cardiac cycle, remember, you will have systole and diastole. There will be an atrial systole and atrial diastole, atrial ventricular systole and diastole, and things like that are all seen here. Okay, now there we go. Okay. Now, let's talk about heart rate. Heart rate's how fast the heart beats, as we should know. Now, it's somewhere between 70 to 100 beats per minute in a normal heart rate. Now, it can be higher, of course. Now, if your heart is abnormally slow, you're not, this could be caused by a variety of things. It's called bradycardia. I oftentimes think about the Brady Bunch. Not a very exciting show was the Brady Bunch, the TV show The Brady Bunch. It was not a very exciting show. So bradycardia is abnormally slow. But tachycardia is very fast. If somebody shows up to a fancy dinner party wearing a halter top and fishnet stockings, you might say they are dressed very tacky. They're dressed too fast for this party. They look like a lady of the evening. That's so tacky. It's a tachycardia, very fast heart rate tachycardia. Now, if I want to measure this, there's a handful of ways to measure heart rate. One of those common ways is, of course, through the pulse. By feeling like in a neck or a wrist is the common places to feel the pulse. As ventricular systole occurs and diastole, the lub-dub, will cause this to happen. Now, you can also measure heart rate as well through an electrocardiograph, an ECG or EKG. It measures heart's rate because you can use little grids and figure out and measure a heart rate there just by looking at it. But it is the heart's activity is tied to heart rate, so it is possible to also determine that. And another way is through auscultation, which is just listening to the heart. You take a stethoscope, place it, you can hear the heart sounds, and begin to hear the lub dub, lub dub, lub dub, lub dub, lub dub, lub dub, and be able to get that sound, okay, and tie that to also a heart rate. But very common is a pulse is just to feel an artery, like the neck and the carotid, like the carotid artery, feeling a radial or ulnar artery at the wrist. Two very common ones to get that. Auscultation is used to other things, is also to listen to heart sounds for murmurs, prolapses, things like that, defects, swirls, and things that may be happening in the heart due to issues of the heart itself. Now, one thing I do want to talk about, and this is very big, and we're going to spend some time on it, is a normal EKG tracing. What does a normal EKG tracing look like? Now, the normal EKG tracing that I want to make sure we talk about here is a thing that if you understand the things we're going to talk about, it will help you when you actually have to go and measure and understand them yourself in a clinical setting. Now, part of this is just using a section of the ABCs, A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P. You have what is called a P wave. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, and T wave. So we have what is referred to as a QRS complex. QRS complex. Now, what is happening during these, and this is tied to heart rate and things like that. Let's look at each one of these. Now, we know that atria depolarize and contract first because the SA node. And then so the atria will depolarize, atria repolarize, ventricles depolarize, ventricles repolarize. Now, a great thing that you guys want to make sure you understand with the P wave is this means the atria will depolarize. Atria will depolarize. This is telling me that if they are depolarizing, they will soon contract. Okay? This is telling me if the atria have depolarized, they will soon contract. Now, the QRS complex, what it is telling me is the ventricles have depolarized. They have depolarized. And they are going to soon contract. Now, a great question that I ask sometimes, not on exams, but I do ask students to see if they can kind of tell me, is where do the atria repolarize? Well, it would be around this time frame here, but the QRS complex will hide it. That is a great question to ask. If I was teaching a clinical course, that would be a question I would have on an exam. Absolutely. Great question. It's obfuscated by this. It's hidden. And the reason it's so big is the ventricles are so big. Now, the T wave tells me my ventricles have repolarized. So they're getting ready to relax. Now, such as there is this area between here, like PQ interval, ST interval, loads of other things that happen, like ST elevated myocardial infarction, STEMI, things like that. So there's some aberrations that may be seen. For example, you may begin to see that if you have potassium deficiencies, you will see changes to EKG. If you can't repolarize, then you may see decreases if you have too little, etc. You may begin to see changes to EKG when it comes to hypokalemia, hyponatremia, hyperkalemia, hypokalemia. That's high and low sodium and high and low potassium. So loads of things. Hyper and hypocalcemia, loads of things. One of my students told me they literally had a doctor come in and write on the chart that a patient had hypopotassemia. And when she told me that, I kind of face palmed. It's like, no, it's hypokalemia. And she's like, yeah, I know. She's a nurse. And it's like, oh gosh, I can't believe that. Now, very important that we know these things, and I'm going to tell you because it's now when you know, if you're my student and you hear me say something is very important, you know you're going to see it on an exam, so you better know what happens at each of these things. What happens at the P wave, the QRX, and the T wave. Okay, now those are very big things. And I went ahead and just explained everything that is on here and things like that. Okay. So basically, you could see the events of an EKG are referencing and tracing the electrical system events that time and coordinate a heart muscle's contractions. And with that, we can really see it very well. Now, part of this normal EKG tracing and why it is the way it is the physiology of this, and also part of the machine, how the machine works, the leads. Now, as I said, during auscultation, I'll listen to the heart. Now, normally, a clinician should only hear sound 1 and 2. Now, sound 3 and 4 definitely references that there's some issues like AV valve defect, things like that, stenosis of valve, issues like that, prolapses, patent foramen ovale, things like that. Now, the first one, we call it the lub, and the second we call the dub, or the dup. As those people say dup. I always say lub dub for some reason, but lub dup is how a lot of books will say it, and I don't think it really matters as much as the nomenclature used here. S1 sounds are made when you close AV valves, when the AV valves are slamming shut. Semilunar slamming shut creates the S2 sounds. Now, again, the S1 and S2 sounds can also sound peculiar due to malformities, malfunctions, disease, other issues. Now, blood flowing through ventricles. Normally you wouldn't hear it, but as it goes into the ventricle, maybe there's an interventricular septal defect. Then you may hear a weird sound. If there's valve defects and blood is going through it, you may hear weird sounds. If the atria, if you have a patent foramen ovale, if the foramen ovale didn't close up after birth and now you don't have a fossa ovalis, you would hear weird noises during atrial contractions. Perhaps they have other issues going on as well. You could actually hear these, and they tend to present themselves at certain issues during certain phases of cardiac cycle, which is one of the main contributing factors to actually identify them. So there's the reasons you learn these things. Students are always like, I can't believe he makes us learn all this. He makes us learn so much, but you have to use it, and they're going to assume you know it when you come in. Now, loads of words that I've got to help you understand. And you will hear me a lot of times says, let me help you understand it, because that is just, it's not just my job to put it out there. I see my job is to help students grasp the content, understand what is happening. If you can understand your way through it, you can better know it. We're going to talk about end diastolic volume, end systolic volume, and then stroke volume first. Now, let's talk about these things. Now, when we talked about cardiac cycle, we said that there was a period of time which blood flows in and blood flows out of the heart and out of the ventricle. So let's just take and do left ventricle here. Let's just think about our left ventricle right here, LV. Let's just think about our left ventricle. Now, remember that at the end of ventricular diastole, there was amount of blood. You had blood in the atria. First came in, passively filled the ventricle, mostly full of blood. Then the atria squeezed and filled it the rest of the way with blood while the atria was relaxed. And there will be a certain volume of blood in here. That blood is called the end diastolic volume, the amount of blood in a ventricle at the end of ventricular diastole, hence end diastolic volume, the volume of blood in the ventricle at the end of diastole of the ventricle, okay, end diastolic volume. Now, what is going to happen is the ventricles contract, they undergo isovolumetric contraction first, then they undergo what is referred to as the cardiac ejection. So this blood will begin to be squeezed out, and going out our aorta. And what is going to be left is a volume of blood at the end of ventricular systole called the end systolic volume. The volume of blood left in the ventricle at the end of ventricular systole. So there is still some left over. Now, if you probably thought, right here is the blood I've moved. I was full of this. This is what's left, and this is the blood that I move. So this volume of blood right here is how much was going out. It is called a stroke volume. Now, let's use this analogy. This is an analogy I use because I live in the South in America, and in the South in America, if your grandmother, basically, Southern grandmothers are definitely like this, but if you are like really hungry after you finished a meal and like you're starving and Granny's like, hey, here's some more food, have some more for us. Like, oh yeah, Granny, I could eat a little bit. She's gonna fill your plate up full, okay? And you can eat it. But now, like, if you are just a little bit hungry, you're like, Granny, I couldn't possibly eat another bite. She said, here, at least take a little bit, and she'll put it on your plate. If she's offering you food and you can't eat anymore, you just have to shoot her. That's it. There is no doing this. Now, one thing we will know is Granny will be very mad if she has too much leftovers, though. That means that her cooking wasn't good. Now, my granny, so we always kind of refer to grandmothers. My granny looked at me one time and said, honey, if we knew about cholesterol when I was a kid, we would have fried it and made gravy out of it. So, Granny, she makes a very big meal for her family. And her family eats, and there might be a little bit of leftovers. Hopefully, Granny doesn't want any leftovers. Now, if we were to go and figure out how much food Grandma made, how much food was left after everybody ate, we would know how much food was ate. Okay? That's basically what's going on here. So, we could say stroke volume is equivalent to the end diastolic volume minus the end systolic volume. And that will tell you how much a stroke volume is how much I start with, how much I've got left, tells me how much went out. Now, you can measure these volumes with an echo. It's a little bit harder to measure this, so there are methods to do that. We usually measure these volumes with an echo, and then we mathematically calculate them. So now that means you will need to know the equation that stroke volume is EDV minus ESV. So end diastolic volume, amount of blood left in each ventricle at the end of ventricular diastole. It's what's there at the start of ventricular systole. And then ventricular systole happens. There will be blood left over. That is the blood that is there when ventricular diastole begins. So, and that's what's going to be available to receive the blood that's coming in during diastole. It's the remaining. So think of EDV as how much food Granny cooked. Think of ESV as how much food Granny served, her leftovers rather, how much food Granny's leftovers. And stroke volume is how much food Granny served. There we go. I got my analogy messed up there a minute. Now, that is the amount of blood pumped with each beat, with one heartbeat. Now, there's going to be a percentage of EDV represented by stroke volume. We'll talk about that in a minute. It's called an ejection fraction, and we'll calculate that. Now, cardiac output is how much is supplied by a left ventricle in a minute. How much blood am I getting to the body each minute? Now, this value is changing. Now, when we are very interested in patients' cardiac outputs, it is a very important thing to know. Usually we have to kind of go and do some math, but sometimes we have to accurately measure it. But usually we estimate it through either one of the ways to estimate some of these values is like using blood pressure, doing a calculation, and with heart rate, we can go and find a cardiac output. And these things are needed to know is the patient getting a blood supply they need. Okay. Now, again, what is cardiac output? That's heart rate times stroke volume. Now, so what we have to think is, okay, this is just one fire. So imagine the heart is like the engine in your car. If the engine of the car just fires one time, okay, that's only going to get you so far. Now, over a period of time, it's kind of like finding out how many miles per gallon you got, okay? So if I have a cardiac output, this is going to tell me if I have my stroke volume, this is how much blood I pump with one heartbeat. Well, there are many heartbeats, like 100,000 heartbeats a day or some more. So obviously, I need to know my heart rate. So if I take one pump and multiply it by how many beats, the cardiac output will tell me how much blood I supply per minute. Basically, you have stroke volume is measured in milliliters, heart rate is in beats per minute, and cardiac output is in milliliters a minute. Okay? Is basically what you're dealing with here. Okay? A very important thing. Cardiac output is stroke volume times heart rate. Okay? Very important that we know. First off, commit these to memory. They will not be given to you. You will have to memorize them. Okay? These need to be in there. Real quick side story, because I do oftentimes tell these, and it's kind of like things. Students are like, why you make us learn this? Why do you have us do this? This isn't fair. And so I had a student, and really a good student, solid student, hardworking student. They are a nurse at our local Veterans Administration hospital. And she comes to me and she's like, I'm so upset. Why do we have to do this? The other professors, my friends in this class at this college and in this class at the same college, so a different college and the same college, and her friends were not having to learn it. Why were they having to learn it? And she says, well, I'm going to go talk to the cardiac nurse I work with. And I was like, you do that. And I just kind of let her vent because I could tell she was frustrated and sweet lady, absolutely, so she goes and she comes back the next class, kind of has like a little sheepish, comes up. She has a piece of paper in her hand, and these terms were all over the equations. And the nurse says, these are the equations I have to calculate every single day, multiple times a day in my head. And she was like, okay, I see why it's like, yeah, if you don't learn them now, you're just in trouble later. Okay. So these are terms that are used in almost every single thing in the day-to-day treatment of cardiac patients. Okay. Now, as we run through these, this is a very important thing. Now, what I want to do is kind of mathematically at first, then we'll mathematically prove it. But what I want to do is kind of look at this. And I'm using red because it's cardiovascular. Now, one of these things we need to make sure is, and let's just kind of do this. I'm going to show you guys kind of the basics and mathematics behind that. Sorry, I clicked on that. Now, a normal EDV is 130 and a normal ESV is 50 mils. Okay. So let's say I have stroke volume. That's right. I'll write it right here. That stroke volume is equal to 130 minus 50. Now, if we're doing that, remember here, and 130 minus 50, that you're dealing with 80 here. Okay, 130 minus 50, 80 milliliters. So stroke volume equals 80. Okay, now let's try something here. Let's look at if stroke volume equaled 140 minus 50. So what have we done here? I've increased the EDV. So stroke volume is equal to 140. Let's say the EDV went up to 140. And now I've got 140 minus 50. You're looking at SV equals 90 milliliters. So when EDV went up, this caused stroke volume to go up. Okay. Now let's do another one. Let's say stroke volume here was 120, and we'll keep our ESV at 50. Okay. So 120 minus 50. That one is 70. So that means stroke volume is 70. So what do? We decrease the EDV, and that means I decrease the stroke volume. Now let's think about this. Again, let's use Granny's supper. Granny makes a lot of food, and that means you can eat more food. If Granny makes less food, you eat less food. Okay, if ESV stays the same. Okay, so this relationship that EDV, first thing I want to kind of say here is when EDV and EDV and stroke volume, what you're seeing is they always go in the same direction. Okay, EDV and stroke volume always go in the same direction. Okay, now let's go and do a normal one again. A normal 130 minus 60. 130 minus 60. Normal EDV increased ESV. So now stroke volume is 70. Remember, normal, right here, normal is 80, so we go down. Oh, sorry, this is the right SV. Very important. Very important, okay? Very important thing here. I'll write this correct in a minute. There we go. It's I always need to kind of have a little laugh at myself when I do something like that. Now let's go back here. Let's keep our normal EDV at 130, but now let's go to 40 for our ESV. So now we have a decreased ESV. Now that is 130 minus 40. Now that stroke volume is 90. So what have we done here? We have increased our stroke volume. So what you're noticing is that ESV and stroke volume go opposite directions, where EDV and stroke volume go in the same directions. Okay? That is an extremely important phenomenon to understand. Okay? Okay? And I've just mathematically proved it. And then I gave some examples here of just what happens when I do a few things. But I did all of them there for you. So you could see an EDV. You could see a ESV. And you could see a stroke volume is the difference between the two. Okay? This is what happens during cardiac ejection, okay, of normal cardiac cycle. Okay. Now, ejection fraction. I'm going to go over here and do an ejection fraction. Ejection fraction is calculated by taking your stroke volume and dividing it by the EDV. And then you multiply it by 100 to get the percentage, okay? So let's say we had somebody who had a stroke volume normally of 80 with a normal EDV of 130 is 62%. That means 62% of the EDV pumped out. Stroke volume was 62% of the EDV, okay? That is a very important thing. There are drugs that will influence the ejection fraction. Okay, ejection fraction will be influenced by cardiomyopathies and things like that, issues going on, and drugs will begin to influence them. So you have to understand and you'll have to watch, is the ejection fraction increasing or decreasing? Is it where we want it to be? Is it normal for this patient? The patient's had a heart attack and we want to watch certain parameters. These things need to be constantly monitored. Okay, you have to understand why it is that you're doing that. When I hear people say, in healthcare, I don't need to know this, I cringe and I would never let you anywhere near someone I love. Okay, so I'm just saying. I love this. I shared it, and a former colleague of mine, somebody I went to graduate school with, they were like, "I want to use this in my class." But it gets so busy sometimes. So this shows you all the forces. I just kind of love it. Sometimes it gets a little bit too much. I wish I could just go like pause, but it doesn't do it. Okay, what I am going to do is have you guys calculate these, and these are practice sample calculations. There are things you may have to do. Cardiac outputs, stroke volumes, ejection fractions. I kind of like flipped them around a little bit here. EF is ejection fraction. I give you guys the beats per minute, the EDVs, the ESVs. Sometimes you don't need all of those things. Sometimes you do. Sometimes it's like, why didn't you give us this? It's like, oh, because you need that. Then you'll need these two things to find the first one. And then you'll need the first one and the information above it to find the second one. And that's all on purpose. It is me making sure you understand what you're doing. And you'll practice these. And then there's plenty of practice problems in the chapter review that I've given as well. So definitely will not be short as you're doing that. And then I gave you guys 2 patients with things that we measured for these patients. It's like, whoa, that's a really high EDV. That probably should just be 140 instead of 1,140. I don't think a ventricle could hold that much. Maybe I went a little bit too overboard. I know it's unrealistic. It's okay. Okay. Now, let's talk about the last and one of the most complex things we do is the factors that can influence our stroke volume. Now, stroke volume, we know with this drawing right here that if I want to influence stroke volume, I can change EDV and I can change ESV. Okay, changing EDV and changing ESV, we know will influence stroke volume. Okay, change these two parameters and you change this parameter. Okay, so let's talk about it. First thing is filling time. Okay, filling time can affect EDV. Now, let me explain filling time to you guys a little bit. And a good way to think about filling time. Let's imagine I have a bucket that I want to fill with water. And I've only, now that bucket, I've got a faucet, and I put the bucket under the faucet and start filling it up. Now, if I immediately pick the bucket up, like just a second after I turn the faucet on, I didn't give it enough time to fill up. I took the bucket away before there was enough time to let the faucet have enough water to fill the bucket up. The bucket never filled up because I took the bucket away too soon. So I would need to leave the bucket under the faucet longer to fill it full of water. Okay? And the same thing goes with ventricles. Is during ventricular diastole, if ventricular diastole lasts a little longer, the ventricles may fill up with more blood. Now, there is a diminished return. There's only so much. But if I take filling time, ventricular diastole, and I shorten it, that's like taking the bucket away, taking the bucket out from under the faucet too soon, and we didn't get very much water into the bucket. But leaving the bucket under the faucet and give it enough time to fill up with water, increase that. Now, so if I increase filling time, I'm going to increase the EDV. And we know if EDV goes up, stroke volume goes up, because EDV, stroke volume goes same direction. Now, if I decrease filling time, if I take the bucket out from under the faucet before I had time to fill up, EDV goes down. I decrease the EDV. If I decrease EDV, I must also decrease stroke volume because EDV and stroke volume go in the same directions. Venous return. That's how much blood flow there is to the atrium, especially the right atrium. The rate of blood flow during a ventricular diastole. If blood is coming in a lot quicker, it is much like any pump. The more that you're bringing into the pump, the more that goes out of the pump. More blood in, more blood out. So an increased venous return will ultimately result in increased stroke volume. Okay? More blood in, more blood out. This is called the Frank-Starling principle. Tattoo that on you somewhere. Tattoo that on your wrist. More blood in, more blood out. Then that stroke volume increases as a factor of increased venous return. Frank-Starling's principle must be known. You will see this all day early in healthcare. Healthcare fields, the Frank-Starling principle is crucial. And you better know it. And when I say you better know it, you probably know what that means. But I'm not saying it because remember, you don't just study to pass a test. You study because one day you're going to be the only thing between a patient and the grave. Okay? So, all right, we have that. Now, again, EDV, ESV. So ESV, let's change ESV. Now, three major things affect ESV. Preload, which is preload is kind of a little bit due to increased venous return. Increased venous return is the rate of flow. Preload is due to the increased venous return, the atrial wall stretches. Okay? Now that means that if I increase this, my EDV goes up, my stroke volume goes up. And also ESV will go down. typically, because the heart undergoes this reflex that makes it squeeze harder. Um, if you decrease the preload, EDV goes down, stroke volume goes down, and ESV usually goes up because the heart won't squeeze as hard. And that's called contractility, or inotropy, is how hard the ventricle contracts. Now, that's very important. You will give to patients anti-inotropic drugs like calcium channel blockers, things like this. Okay? Things that can affect how hard the heart beats, anti-inotropics. Now, there are hormones, the autonomic nervous system, and how active you are. For example, the autonomic nervous system, sympathetic, can make the heart squeeze harder. Excellent physical activity can make the heart work better, more effectively, and more efficiently. But if I increase contractility, stroke volume goes up because I squeeze harder, ESV goes down. But if contractility goes down, stroke volume drops because my ESV went up because I didn't squeeze as hard. Okay? It's like a tube of toothpaste. If you increase how hard you squeeze on the tube of toothpaste, more toothpaste comes out. If you decrease how hard you squeeze on a tube of toothpaste, less toothpaste comes out. Okay? Think of contractility is like squeezing on a tube of toothpaste. And then afterload. Afterload is what is the tension the ventricles have to produce to open the semilunars. Your semilunars have blood pushing down onto the semilunar valves in the pulmonary trunk, in the aorta, and that is a mass, a force exerted on it that must be overcome. So if anything ever increases the afterload, for example, vasoconstriction would increase afterload. It'd make it harder to do a cardiac ejection. Malformed valve may increase the afterload. Anything that increases pressure, especially diastolic pressures, things like that, can increase the afterload. So what this is, guys, is our afterload here. If it is increased, ESV goes up. If you make it harder for blood to come out of the heart, there will be more blood left in the heart. Okay? It's kind of like a prison. If you make it harder to escape the prison, more prisoners will remain in the prison. Afterload is extremely impacted by vasodilation, vasoconstriction. For example, if you vasodilate, it's easier to let blood out of the heart. If you vasoconstrict, it's harder. Now, I also like to think of it like this. And when I'm in class, when I teach this in class, I bring my little gravel flipper. I have a little Dennis the Menace gravel flipper that I bring to class, and I always have it in my back pocket like Dennis the Menace when I teach. And I would bring this sucker, and I would shoot like my Coca-Cola can. I might bring empty Coke can that I have. Maybe I went and grabbed a cherry Coke out of the vending machines around over in the student center, or the ones over there in the faculty building. Went up to somewhere to, like, I just need a little pick me up, need a little shot. And so preload would be like me going in and loading the rock and pulling that rock back. If you have a little gravel flipper and you grab a rock and you're going to flip it and you pull that back, that's the preload, the stretching that band back. Now, the band that I'm using, if I'm using a very thick, heavy rubber band, that's going to have a lot of contractility. So if I let go of it, it's going to fling that rock hard. But what if I used a very weak, old rubber band? It might not stretch. It may not have much force when you let go, or maybe or a very weak piece of elastic or something. It depends on how effective that thing can actually let go. Afterload would be the rock hitting the can. Now, if the can's full, it might not be able to knock it over because there was too much afterload. And if the can was empty, it might be easy to knock it over because there was less afterload. Okay? So, very important factors affecting stroke volume. Okay? So, Now, as we go through this, I was talking about this reflex referred to as a Bainbridge reflex or atrial reflex, a heart rate adjustment due to the increase in venous return. The heart, as it stretches, as the preload increases, heart rate goes up, increased sympathetic activity. Now, contractility, sympathetic stimulation. Norepinephrine, for example, goes from the cardiac nerves, and epinephrine and norepinephrine, both from adrenal medulla, will cause the ventricular muscles to squeeze harder. Okay, it's going to use CAMP signaling system in these cells to bring in more calcium through calcium channels, which will cause a greater amount of contractility by increasing the active site exposures and things like that. Parasympathetic acetylcholine by vagal stimulation reduces cardiac contractions. Okay. And this reduces your stroke volume and increases ESV. But if you are squeezing harder, stroke volume goes up and ESV goes down. Okay. Hormones, loads of hormones. Now, what we try to do is, since loads of hormones can affect things like your epinephrine, norepinephrine, thyroid hormones, things like this, these drugs can go in. So sometimes what we do is we find drugs that mimic them or block them. We can stimulate or block a beta receptor with pharmaceutical drugs, or we can affect ion channels like your calcium channel blockers to affect contractility. Okay. Usually you can go in and find a blocker like a beta blocker or something like that, or stimulate them, anti-inotropics or positive inotropics, both pro-inotropic drugs, things that make positive inotropics. Okay. Now, afterload, remember, if I have a vasodilation, that makes it easier to pump blood out. So that reduced afterload reduces ESV and increases stroke volume. But if I vasoconstrict, it's harder to get the blood out, so afterload is increased. So now it's harder to eject blood. So ESV goes up and stroke volume goes down as well. Remember, ESV and stroke volume opposite. Now, so if afterload increases, stroke volume decreases. If afterload decreases, stroke volume increases. Okay, afterload, if it goes up, it increases ESV. And you can see all this right here, okay? All these nice little things showing us how we can affect our overall cardiodynamics and stroke volume, okay? Now, how do we affect heart rate? Well, there's going to be three major ways, which you've already seen here. And the three major ways are going to be your autonomic nervous system, hormones, and that increased venous return due to the Bainbridge reflex. Now, we have at play here is our autonomic nervous system to control cardiac muscle, controlling the conducting system. Now, for example, the cardiac plexus has in it sympathetic and parasympathetic nervous system neurons, and they attach to the SA node. Now, there is actually far greater amounts of sympathetic innervation for two reasons: suprarenal medulla and neural, both. Double dose of sympathetic. Now, in the medulla oblongata, there are the gas pedal and the brake of the heart. The gas pedal is the cardio-acceleratory center. We oftentimes call the gas pedal the accelerator. Especially in America, we all kind of like our cars, and I had you just spend today a lot of money on mine. I'm sitting there saying, honey, let's just go down to the Dodge dealership and let me get my Challenger. Probably be just as much. You might as well just go ahead and get a new Dodge Challenger for me. 5.7 liter V8. Okay. That didn't work. Except 3 years. Okay. So that would be your gas pedal. Cardio inhibitory centers, that's your brakes. It's going to slow things down. So cardio acceleratory centers increase the heart rate. Cardio inhibitory centers decrease heart rate. Now, hormones, epinephrine, norepinephrine, thyroid hormones, these all make the heart rate go up. This is why people who have hyperthyroidism will have very high heart rates. They'll feel very anxious. Their heart rate's like their heart's beating out of their chest. They get to have some high overactive thyroid, hyperthyroidism. Now, also, there will be venous return. Remember, if you have more blood in, there will be more blood out. The factor of blood stretching the atrial wall Bainbridge reflex increases the heart rate to remove the blood. And you could see our cardiac inhibitory centers and acceleratory centers sending information out through the vagus and things like that, through the cardiac plexus of neurons to control the heartbeat and inotropy and all that. Okay. Now, all this shows you that if I affect cardiac output, I need to either control the stroke volume. To control stroke volume, I need to change EDV and ESV, heart rate, and these factors are affected by things like hormones and the autonomic nervous system, the amount of blood coming back to the heart, things like that. And this is all tied to the cardiac control of the conducting system, which affects the timing, the firing, and the rate. All these things tying together to ensure the heart works the way it's supposed to do. Like an engine in a car that should not be backfiring, sputtering, and pinging. It shouldn't have pre-ignition. It shouldn't ping. It shouldn't sputter. It does remind me because every time I talk about this, it always reminds me because when I was in college, I had a pickup truck that had shorts in the wires, and it would just sputter. And I was trying to get to college, didn't have a lot of money. Finally, got the money to go and replace all these. Got some, uh, just trying. It was so hard, of course, when you're a poor college student. Um, so always makes you think because they would just sputter and just have some problems. You could just hear it. And I was like, oh gosh, it's like when I'm gonna get this thing fixed. And so, all right, these diseases are not on the exam. I have listed them here. I'm not going to go over them because I do not actually have them on the test, but they are there, and I usually like to talk about that. And here's some congenital heart defects. This was a Nobel Prize winning device to keep a heart. If somebody had just died, we put their heart in and keep it going, pumping blood through it, keeps it. It has allowed us to have hearts that we would have lost that is now available for transplant when we wouldn't have had it. Very freaky looking, isn't it? So, that is everybody's favorite side. Guys, thank you so much for this. I hope you guys enjoyed it. I hope that I explained things for you very well. I definitely worked my hardest to explain and make sure that I can show you guys how to do this. But thank you so much. If you like it, let me know. And but also, since it is also going on YouTube, but this is also for an ongoing class as well. Look forward to seeing you guys on Friday study group who have my classes. So hope to see you there. Thank you guys. Have a great day. Bye.